Hi, our final chapter in endocrinology. We have saved the most confusing for last. And in fact, it's not as confusing as adrenal. Adrenal is confusing because it truly is difficult. Female reproductive system is confusing only because there are certain things that you have to accept that make no sense. Once you accept that they make no sense, you'll be fine. Now, the first part about this, and this is going to be very repetitious for some of you, the interesting thing is I'm going to say everything 5 times, and some of you be like, man, why is he saying this 5 times? I got it on the first time. And some of you be like, how come you only said it once? We're saying the same information. The menstrual cycle. So the first thing, the first day of the menstrual cycle is when you bleed. Why not take ovulation as the first day? Because you can't see it. You can't see it. You can't see it happening. We take menses, the bleeding is day 1 because you can see it. You know, although my first love, Shelley, she always could swear. She's like, I'm ovulating, I know I am. I just dropped an egg. She always swore. She could tell it when she was dropping eggs. Okay, my life with bulimic women who can swear they know exactly to the moment when they're ovulating. But for the rest of us, we can't tell when we're dropping eggs. But we can tell when we're menstruating. Now, here's the first part. The first part of the cycle is follicular phase, which is very well named because it's when the follicle's growing. Now, here's the first part. Which of the following varies in length? The follicular phase varies in length. Sometimes the follicle takes 12 days to grow, sometimes 14, sometimes 16. The length of the follicle growth is variable. First point. Although it's first 2 weeks on average, some people have 26-day cycles, some people 32-day cycles, some people it varies cycle to cycle. So what varies? Follicular phase. A woman comes to you. Her cycles vary in length from 26 to 36 days. Which of the following is most likely to be varying? The follicular phase, the date of ovulation, the luteal phase. The answer is the follicular phase. Now, during the follicular phase, the main part of it is estrogen. Estrogen makes endometrial cells grow. So the estrogen makes the lining cells grow. Follicular phase, variable endometrial lining cells. Biggie. Ovulation. Here's our main question about ovulation. If you have a cycle length, the ovulation is always 14 days minus the cycle length. If you have a cycle length of 34 days, you ovulated on day 20. If you have a cycle length of 1,014 days, you ovulated on day 1,000. Because the luteal phase is always 2 weeks. The total cycle length, whenever you take the total cycle length, subtract 14 days from it, that's when you ovulated. Because the luteal phase is always fixed. Now, the luteal phase is fixed, follicular phase is variable, and the ovulation is 2 weeks before the end of the cycle. 2 weeks before the end of the cycle. Okay. The luteal phase. Luteum literally means yellow. Corpus luteum. Yellow body. Body yellow, to be precise. Lupus corpus luteum. Body yellow. Why is it yellow? It's greasy. Progesterone is greasy. Follicular phase. Variable. Estrogen. Endometrial lining. Luteal phase. Fixed. Progesterone. Secretions on the endometrial lining. Menstruation, passive phenomena. Menstruation, loss of estrogen and progesterone, the endometrium sloughs off. The main question, passive phenomena. Now, this picture is going to repeat a lot in your textbook. Now, the first part of this is to say, follicular phase, characterized by estrogen. Follicular phase by estrogen. Follicular phase by estrogen. Ovulation, luteinizing hormone. Luteal phase, fixed in length. And luteal phase, progesterone. There it is again. Day 1 is menstruation because we can see it. You can't tell when you're ovulating. We don't know what the point of the FSH surge in the middle is. We're not sure what to do with that. we do know the LH surge makes the ovulation occur. Okay. Now, here we have our schematic, and here's our friend the hypothalamus making gonadotropin-releasing hormone. Now, when the hypothalamus is making gonadotropin-releasing hormone, now that same GnRH makes LH and FSH. Wow, that's reminiscent. That's just what happened in the man. Now, the interesting thing is that the same GnRH from the hypothalamus, the same FSH and LH that used to work on Leydig and Sertoli cells are now working on granulosa and theca cells. Theca and granulosa cells. Fantastic, isn't it? You get the same hormones working on two completely different cells. Now, this machinery in the middle, in the theca cell, is the same enzymatic machinery that we saw in the adrenal gland. It's the same enzymatic machinery we saw in the adrenal gland. Wow. Now, the theca cell just takes it to an androgen, like adrenal androgen, DHEA, and it is only in the granulosa cell that aromatase converts it to the final step. So, this machinery is the same machinery we saw in the adrenal. What makes it an ovary? Because it's got some more enzymatic steps. The adrenal gland does not have aromatase. Here's our friend the inhibins, a hormone walking around looking for a purpose in life. Who am I? I'm inhibin. What am I here for? When I'm deficient, nobody misses me. When I'm in excess, nobody's ever heard of that. What's my point here? It's a hormone within an identity crisis. The estrogen, now here's a testable point. The estrogen inhibits both FSH and LH. Which one does it inhibit more? Da 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 da. It inhibits FSH more. And the reason it inhibits FSH more is because we only want there to be one developing follicle. You see, when we have an ovary, and this is an ovary, at the beginning of the cycle there are a lot of eggs developing, lots of them. And then over time, we get only a few of them that survive. And then over time, a tiny number. And then finally, over time, we get only one good follicle, which is ready to burst. Well, as we go around the cycle like that in the follicular phase, we start out with a lot of eggs cooking up, then smaller and smaller. So it inhibits FSH more because we don't want to use up all the oocytes that we had in the ovary, because you'll run out. You'll be postmenopausal at 30. The second thing is this: if you release and ovulate 5 eggs at the same time, nobody wants to have 5 and 10 little bitty babies. Octuplets don't survive generally, despite the recent thing. Mostly, we don't want to have 8 and 10 babies, because if you have 8 and 10 little babies like that, survival for babies is very much related to birth weight. 2 or 3 pounds over, you don't survive so well. 2 or 3 pounds under, you don't survive so well. So that's why we inhibit FSH more, because we want only one egg to be good. Hence the American idiom, he's a good egg. So we want to inhibit FSH so the estrogen stays inside the follicle, and the estrogen also goes back to the pituitary to shut off FSH. Let's go back to the picture. And what we see here is, you notice that FSH is going down, 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 down. That effect of FSH going down, down, down is the same as the estrogen level going up. The estrogen level goes up and the FSH level goes down. Why? Because we don't want 10 follicles germinating. 1. Next, estrogen stays in the follicle for it to develop and goes to the pituitary to shut off FSH. We want one good ovulated egg. The follicular phase is variable. The major product is estrogen. In the follicular phase, the estrogen is inhibitory or stimulatory on the pituitary. It's inhibitory for most of the cycle. Now you might be saying, Gee, what's been so hard about female reproductive? That seems straightforward. Follicular phase is variable. Luteal phase is fixed, 2 weeks. LH surge makes ovulation. First day of the period, bleeding, is the first day of the cycle. What's so hard? Estrogen inhibits the pituitary. Estrogen inhibits FSH because we only want one follicle. What's so hard? The next thing I'm going to say. The next thing I'm going to say is hard because something changes. Now, let's look at our estrogen again. Estrogen by the granulosa cells. Produced by the granulosa cells, you could say produced, you could say activated, you could say converted by aromatase. Estrogens make a woman. Sex accessory organs, you know, you like that? Access organs? I guess so, in a way. Okay? Estrogens cause the endometrial cells to grow. Estrogens also make the mucus thin because we want the sperm to make it easier to get in there. Swim, 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 swim. Okay, so far that's not anything different. Now, here's where I start to say something different. The estrogen level starts to go up. The FSH level starts to go down. Estrogen, is it inhibitory or stimulatory on FSH? It's inhibitory. Is the estrogen inhibitory or stimulatory on LH? It's inhibitory. Now is the big switch-o change. Are you ready? You ready? Estrogen is inhibitory on FSH and LH until it gets to a certain level. And once the estrogen level gets to a certain level, it switches from being inhibitory to being stimulatory. You will not find out why. It's part of the system. If you can accept that, you're going to do fine. There's 2 or 3 things in the cycle here you just have to accept is what happens. When estrogen levels go above a certain amount, they stop being inhibitory, and they switch to being stimulatory. And then the FSH and the LH go up. And then they make more estrogen. And the estrogen makes more FSH and LH. And the FSH and LH make more estrogen. And the more estrogen makes more FSH, boom! Positive feedback is rare in life, rare in biological systems. Positive feedback is unusual because it creates explosive events. Negative feedback is standard, the norm. TSH makes T4. T4 inhibits TSH. ACTH makes cortisol. Cortisol inhibits ACTH. Growth hormone makes IGF. IGF goes back and shuts off growth hormone. Positive feedback, rare. This is one of the only times. Giving birth and ovulation. Okay, estrogen is inhibitory until it becomes high enough and then it stimulates. Now, once it starts to stimulate under high circulating estrogen, it becomes stimulatory. And then you start getting more FSH and LH. And the FSH and the LH induce ovulation because the FSH and the LH makes more estrogen, and the estrogen makes more FSH and LH, and the LH makes more estrogen, boom! Now here's a weird thing. When the LH surge occurs, the theca and granulosa cells start popping out LH receptors all over the place. It would be like me playing you opera. And all of a sudden, as I start to play opera to you enough, you start all of a sudden growing more ears on your body. You get 5 ears and they start loving opera. Under the influence of luteinizing hormone, everything becomes a corpus luteum. It's kind of like when you're in love, everyone else seems like they're in love too. So under the influence of the luteinizing hormone, everything becomes a corpus luteum. And the LH receptors pop out everywhere. And the whole thing becomes converted into a corpus luteum. when the estrogen level goes above a certain amount, the estrogen switches from being inhibitory to being stimulatory. When it becomes stimulatory, LH and FSH start to surge. Under the influence of the surge of LH receptors pop out all over the place, and the whole thing becomes converted into corpus luteum. Now, the corpus luteum's major product is not estrogen. It is progesterone. Now, here's back to the same picture again. Here's back to the same picture. When the estrogen level starts to go up, this will start to drive up the FSH and the LH levels. But under the influence of luteinizing hormone, remember, a corpus luteum does not make estrogen mostly. A corpus luteum makes progesterone. That's why you see, as the LH level goes up, you will see it converts to progesterone, because the corpus luteum makes progesterone. Now, here's the point we're making. Under the influence of luteinizing hormone, everything becomes converted into a corpus luteum. The major product of the corpus luteum is progesterone. This thing in here is the same machinery that was there before. It's the same machinery as you had in the adrenal, except for the aromatase. We switch to a corpus luteum. The major product of the corpus luteum is progesterone. And it pops. And part of the reason that the estrogen level will go down is that the follicle made the estrogen. But when the follicle ovulates and is burst, it can't make estrogen. It's been destroyed. It's been broken. The corpus luteum makes progesterone. Now, the corpus luteum makes progesterone. The corpus luteum makes progesterone, and the progesterone makes secretions. It's kind of like estrogen grows the salad, and progesterone makes the salad dressing. Now, the progesterone makes the cervical mucus thick because once the sperm get in, it wants to shut off the competition. The other thing is this: progesterone makes you hot. Ay, Dios mío, ay, qué lindo, esta chica es muy caliente. Why is a post-ovulatory female so hot? And the answer is progesterone. Why does it do that? We don't know. Progesterone does something else too. It increases appetite too. You can actually give progesterone to people who have wasting syndrome from cancer. A patient comes with cancer resulting in cachexia and decreased appetite. What is the best initial therapy? Medroxyprogesterone. A patient with cancer and wasting syndrome is treated with medroxyprogesterone and begins to desire to eat and empties the refrigerator. What is the mechanism? Progesterone makes you hot and also stimulates appetite. Back to our friend, the menstrual cycle. The L8 surge causes ovulation. The ovulated follicle breaks the ability to make estrogen, and the ovulated follicle makes progesterone. Estradiol, estrogen, makes the lining. Progesterone makes the secretions on top of that lining. Now, this thing about monitoring the menstrual cycle, this is a bit theoretical in a way, but it comes out to being like this. If you were an egg donor, a patient desires to be an egg donor, about $3,000 to $5,000 for the egg donor, up to $8,000. How do you know when it's time to go in there and grab that egg? Well, as long as the estrogen levels are continuing to rise, you haven't ovulated yet. You want to be an egg donor? It could be up to $8,000 an egg. As long as the estrogen levels are continuing to rise, you haven't ovulated yet. As long as the estrogen levels are continuing to rise, you haven't ovulated yet. When the estrogen levels start to drop, you're about to ovulate. So that means what you do is see that the slowly rising estrogen metabolites, the early follicular phase, but when it starts to rapidly rise, it means you're about to ovulate. When you're about to ovulate, you're going to rapidly rise. However, it's not until the estrogen levels stop rising that you know you're going to ovulate. You monitor the menstrual cycle by this: urinary estrogen levels. As long as they're still rising, you haven't ovulated. When they peak, you're ovulating. Now, when ovulation has occurred, the corpus luteum will last for 14 days. Now, the major product of the corpus luteum is the corpus luteum will make progesterone. Now, progesterone is going to have the effect of decreasing luteinizing hormone. Feedback inhibition. Well, you understand feedback inhibition. Now, what happens, though, is that when the corpus luteum expires, 14 days, it expires like a yogurt. Goes bad after a couple weeks. When the corpus luteum expires, progesterone levels and estrogen levels will go down. Let's look back at that corpus luteum again. The corpus luteum makes progesterone and estrogen. When the corpus luteum expires and these levels plummet, what happens is that the endometrial lining needs that progesterone and estrogen to maintain itself. Without the corpus luteum, then the endometrial lining will slough off. Now, in the new cycle, what you have is you have very low levels of progesterone and estrogen because the corpus luteum has expired. When the progesterone and estrogen levels are low, the feedback inhibition on FSH and LH is removed, and FSH and LH will start to rise again. Ovulation occurs. Boom. The corpus luteum makes mostly progesterone and some estrogen. The corpus luteum will last for 2 weeks. It is fixed. If fertilization has not occurred, the corpus luteum will expire. When the corpus luteum expires, FSH and LH will start to rise again because progesterone and estrogen will go down, FSH and LH will rise, and it starts the whole thing again. The length of the follicular phase is variable. The length of the luteal phase is fixed. The total cycle length minus 14 gives the day of ovulation. That's a question. A woman comes with a cycle length of 24 days. 24 days. When did ovulation occur? Cycle length minus 14. Now, amenorrhea means without menstrual flow, like the word Rio or rheology, river or flow, without menstrual flow. Now, the number of causes of this are pretty extensive, but the first thing always to do is to exclude pregnancy. The first thing always to do is to exclude pregnancy and prolactin. So before you do anything, you're going to exclude pregnancy and prolactin problems. Woman comes, she's got amenorrhea. Oh, my doctor, I don't have my period. Yeah, you're pregnant, honey. Okay? Now, Kalman syndrome is just loss of FSH and LH. Kalman syndrome is loss of FSH and LH, and if you don't have FSH and LH, you can't ovulate. Now, eating disorders will cause you to have amenorrhea because when you go below a certain amount of body fat, the female body will shut off menstruations. Now that is, in terms of natural selection, a good thing because it's kind of like this. The society is starving, the woman is starving, wrong time to get pregnant. Wrong time to get pregnant. When body fat goes below a certain level, when you become malnourished, you shut off menstruation because the body knows wrong time to get pregnant when the species is starving to death. So that's protective. That's protective. People who get pregnant when they're starving die. Now, I don't believe purely in evolution, but we do believe in natural selection. And if you're the person who gets pregnant at the time that you're starving, you get Darwined out. Now, hypothyroidism gives you amenorrhea because of a high prolactin level. Thyrotropin-releasing hormone stimulates prolactin. Pituitary tumors. What is the most common pituitary tumor? Prolactinoma shuts off FSH and LH. Athletes is like the starvation, under conditions of extreme stress, wrong time to get pregnant. Now, why premature ovarian failure is kind of like saying, why did some people go bald at 35 and some people never? It happens. Now, polycystic ovary can also do it because as a part of just polycystic ovarian syndrome is an inhibition of menstruation. Athletes and eating disorders. When the body fat goes down, you shut off menstruation. It's like starvation. Anything that makes prolactin, hypothyroidism, pregnancy, pituitary tumors, shuts off ovulation by inhibiting FSH and LH. Now, polycystic ovarian syndrome, idiopathic, unclear why. Infertility, hair and hirsutism from the androgens. Insulin and obesity and insulin resistance. Well, obesity and insulin resistance always fit together because adipose tissue must have insulin to function. Adipose tissue must have insulin to function. Infertility is the same thing as saying amenorrhea and oligomenorrhea. Those things are synonymous. So saying amenorrhea and oligomenorrhea is the same thing as saying infertility. Hirsutism, because you make abnormal androgens. It's part of the disease. PCOS, you make androgens. Obesity and insulin resistance fit together because everybody with obesity has insulin resistance. Now, the bottom line answer about why this happens is unknown. You get androgens. That's why you get hirsutism. You get androgens so you don't develop follicles. What happens is you become amenorrheic and you lose the ability to become fertilized because you can't get fertilized if you're amenorrheic. So infertility, oligomenorrhea, amenorrhea are saying the same thing. Obesity and insulin resistance are saying the same thing. And hirsutism and high androgens are saying the same thing. Now, hirsutism just means abnormal hair growth. Now, in general, in men, it's equivocal as to whether there's such a thing as a hirsute male. There's definitely hirsute females, but it's hard to say. Virilization is because androgens make you hairy. Now, clitoromegaly happens only if the androgens are pre-pubertal. Increased muscle bulk can happen from the androgens at any time. You could be a 40-year-old woman taking androgens, get increased muscle bulk, but you don't get clitoromegaly. Breast atrophy happens because you need estrogens to make breasts. Now, saying that hirsutism is with androgen excess is sort of saying the same thing twice. Virilization, androgen excess. Virilization, androgen excess. Hirsutism is saying the same thing. Now, you'll notice that it says hair, hirsutism, hair, 4 times in a row. So this slide is a bit repetitious on saying androgens, 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 androgen, androgen, androgen. And then instead of saying androgen, DHEA. Interesting, right? Oop, androgen. Look, we've got 7 androgens on one slide. I get the feeling that hirsutism is associated with androgens. It could be. Maybe if an slide only said it 3 times, I might be convinced. But with 7 times of saying androgens, I'm convinced. So what do you use? Dexamethasone will shut off. Dexamethasone can shut off the adrenal androgen production. Dexamethasone shuts off ACTH. Why do you use dexamethasone? Feedback inhibition on the pituitary, shuts off ACTH, no ACTH, no adrenal androgens. Oh. Also, spironolactone. Why? Anti-androgenic. Anti-androgenic. Believe me, it's a nice thing if you're a woman who's got a big hairy lip and you get spironolactone, you're going to like it because it blocks the androgen effects on the hair follicles. See, androgens for women make them hirsute here and here in abnormal places. and causes male pattern hair loss in women. Look, society is pretty tolerant of my male pattern hair loss. I'm 6'4" and a male. Society is not tolerant of male pattern hair loss in women. So that's one of the things that gets forgotten in the hirsutism story. Hirsutism, virilization, adrenal androgens. It's saying the same thing. You notice how people often forget to say, just as much as you're growing hair in abnormal places, women are going bald. And that doesn't come across so well. Dexamethasone for feedback inhibition on the pituitary. Shuts off ACTH, shuts off adrenal androgens. Spironolactone is anti-androgenic on the hair follicles. Now for men, that anti-androgenic effect makes gynecomastia. But for women, it blocks the abnormal hair production. Pretty cool. Now we're back into cycles of what would happen if you're pregnant. Let's go back into that cycle. You would ovulate at day 14 to day 15. At somewhere around day 15, you fertilize. Now, you have, on average, till about day 20 to get down into that uterus. Go down the fallopian tube, get into the uterus, and implant. So what it means is you ovulate at about day 14. About a day after that, somewhere in the distal third of the fallopian tube, you fertilize. You meet the sperm. Now, you've got to get fertilized and make it down the fallopian tube and implant by day 20 to be able, by day 25, to start to make beta-HCG. If you do not get, one, fertilized successfully, travel down the fallopian tube, implant, and set up that trophoblast to make beta-HCG, menstrual cycle, swashed out. Now, you basically take the gestational age from the first day of the last menstrual period. The most common cause of infertility is low sperm counts. Remember, you blame the man first. You blame the man first, not only low count, but bad morphology. And if the sperm count is low, you cool it. Sperm count is low, be cool. Pregnancy, you implant, you fertilize on day 15. You implant on day 20. The trophoblast has until about day 25 to make beta-HCG. Because beta-HCG, this is a biggie, beta-HCG rescues the corpus luteum. If you don't rescue the corpus luteum, the progesterone and estrogen levels will plummet and the endometrial lining will slough off. If beta-HCG goes up, it rescues the corpus luteum. And if it rescues the corpus luteum will continue to make progesterone and estrogen, and that corpus luteum will be able to sustain the endometrial lining. Unless the beta-HCG goes up, the corpus luteum is lost, and with it, menses. You ovulate on 14. You fertilize on 15. You got 5 days to get yourself down into that uterus and buy a house and set up shop. You got 5 more days, day 25, to make a trophoblast, which makes beta-HCG. Pregnancy test is positive. The beta-HCG rescues the corpus luteum and keeps the progesterone level up. Are you against gestation? No, I'm for gestation. I'm pro-gestation. Progesterone. Now, this slide can be a little bit confusing. It basically says that at the beginning of the cycle, pituitary LH, the first 2 weeks after ovulation, pituitary LH maintains the corpus luteum, which makes the progesterone and the estrogen, which maintains the placenta, the endometrial lining. Once you have implantation, what is at first a trophoblast, and then later becomes a placenta. Now, that HCG maintains the corpus luteum. This is the first trimester. Now, the next question I'm about to say will sound a little psychotic. It basically says, when can you remove the ovary in a pregnant woman? My question is always, why would I want to remove the ovary in a pregnant woman? But physiologically, you need the corpus luteum in the ovary to make progesterone and estrogen for the first third of the pregnancy. It is only in the second trimester that the placenta becomes big enough to make enough progesterone to sustain itself. It is only in the second and third trimester that the placenta makes enough progesterone to maintain itself. LDL is the movable feast that's the source of the cholesterol to make the progesterone. Next, the last thing here about pituitary of the fetus and the adrenal androgens. All right. This is the only diagram that's really hard. The placenta and the baby need a lot of sex hormones to maintain that progesterone. In the first third of the pregnancy, the corpus luteum makes progesterone that maintains the endometrial lining. In the second trimester, the placenta is big enough to make its own progesterone. But what ends up happening is that in order to get enough androgens and estrogen, the mother's placenta sends precursors into the fetus to use the fetal adrenal to make DHEA, to make androgens, which go back into the placenta to be converted into the final step into estrogen. What that means is that the mother uses the fetal adrenal to make extra sex hormones. That's why DHEA is sulfated. Because if it wasn't sulfated, it wouldn't be water soluble. And if it wasn't water soluble, it couldn't make it easily in and across from the fetus's adrenal, from the baby's adrenal, back into mom. Let's say it again. In the first 2 weeks, we have pituitary luteinizing hormone stimulating the corpus luteum to make the estrogen and progesterone that is necessary to maintain the endometrial lining. If there is no fertilization, the corpus luteum will expire in 2 weeks, the progesterone and estrogen levels will go down, the endometrial lining will slough off as a passive phenomenon. If you implant on day 20, by day 25, you're making enough placental beta-HCG to maintain the corpus luteum. HCG is like luteinizing hormone. That makes the estrogen and progesterone we need to maintain the endometrial lining. By the second trimester, the placenta is big enough to make its own progesterone to maintain itself. When it needs even more, it takes advantage of the fetal adrenal to make the precursors which come back to the placenta to make more sex hormones. When can you remove the ovary in pregnancy? As if you wanted to, after the first trimester. Now, the estrogen and the progesterone that are made by the placenta makes all the nice things that mommy needs. She needs to have a big uterus, she needs the muscles, she needs to make the glands in her breasts. But the interesting thing is that under the influence of estrogen is going to do two things. It's going to make prolactin, which is going to make the breasts grow and make the machinery to make the milk. And at the same time, it's going to prevent the milk from flowing. Now, isn't that weird? Estrogen makes prolactin, which likes lactation. Are you against lactation? No, I'm pro-lactation. Estrogen makes prolactin. Prolactin makes the machinery to make the glands. So you got milky glands, but the estrogen prevents it from flowing. Well, of course we don't want the milk to flow. The baby's not been born yet. Why would you put out a glass of milk for you at home if you're not going to be home for 2 months? You can go and get milk. You could put it in the refrigerator, but why pour the glass of milk unless you're ready to drink it? So the estrogen makes the prolactin, which makes the machinery, but the estrogen acts like the cork in the bottle. The estrogen prevents the milk from flowing. Because remember, the bigger the placenta, the more the estrogen, the more the estrogen, the more the prolactin. You make the machinery to make the milk, but you don't let the milk flow. Now, prolactin is secreted by the pituitary in response to estrogen. Now, here's one of our last points for this chapter. Human placental lactogen. A very interesting idea. Human placental lactogen acts like growth hormone, acts as an anti-insulin, makes ketones, prevents the mother from using the glucose. Human placental lactogen is responsible for 2 things. A woman with no history of diabetes in her 3rd trimester is found to have an elevated oral glucose tolerance test with no history of diabetes. Which of the following is the most likely etiology? And the answer is human placental lactogen. Human placental lactogen is an anti-insulin. Human placental lactogen can take genetically predisposed women and push them into gestational diabetes. When there is a condition of starvation and there's limited food for mama, who gets the food first? The baby or the mama? Baby. I'm a glucose molecule and I'm going down a blood vessel in the placenta. I can go into mom or I could go into the baby. Who gets me? The baby. Why? Does the baby have increased affinity or does the mama have decreased uptake? Mama has decreased uptake. Human placental lactogen is an anti-insulin for mama. Human placental lactogen blocks the mother from picking up the glucose, and I go into baby. Under conditions of starvation, human placental lactogen can save the species. If you have 1,000 women who are starving, and one of them has human placental lactogen and the others don't, and those are all pregnant women, the woman who has human placental lactogen will survive to reproduce. I mean, the baby will survive. The women who don't, the mother may survive, but the baby doesn't. That's nice for the mother, but not good for a species. So we don't believe purely in evolution, but we believe in natural selection. Human placental lactogen, gestational diabetes. Human placental lactogen, gestational diabetes in genetically predisposed women. Human placental lactogen, under conditions of starvation, is why the species survives. If you have 1,000 pregnant women and they didn't have human placental lactogen, under conditions of starvation, all the babies would die. It gets selected out. What if you have a mutation that's 1 in 1,000, 1 in 10,000, 1 in 100,000? The woman that has that mutation for human placental lactogen will make more babies, and that's a huge genetic survival advantage. During the 2nd trimester, the pregnancy becomes hyperinsulin. You have more insulin resistance. Now, HCG hits a peak in the first third of the pregnancy. After the first third of the pregnancy, you don't need beta HCG because the placenta becomes big enough to make its own progesterone. HCG comes out of the corpus luteum and the trophoblast. The trophoblast makes the HCG, which supplies the corpus luteum. Prolactin goes up because estrogen goes up. Estrogen is made in the placenta. The placenta makes the prolactin makes the glands, but the milk doesn't flow because you're not there to drink it. Human placental lactogen goes up because that acts as an anti-insulin for the mother. In a normal woman, you don't notice it. In conditions with normally fed women, you don't notice it. Human placental lactogen has two effects. It takes genetically predisposed women and creates gestational diabetes, and it's a guarantee of survival for the species under resource-limited conditions. Under normal conditions, you will not feel human placental lactogen. Now, don't worry about here. It says estrone, estradiol, estriol, whatever. The whole point is progesterone and estrogen go up. Why do they go up? Because the placenta is making it. Why do they go up? Because the fetal adrenal is donating us some DHEA, which is sulfated so we can get it back in the mother. Why do these go up? Because we need estrogen and progesterone to maintain the placenta, to maintain the baby, because we need the estrogen to be able to make the prolactin. Which one does it matter? It doesn't matter. Now, what happens when you're pregnant is you get a 50% increase in plasma volume. You are so juicy when you're pregnant. You are so ripe, so full, so ready to pop. You're like a big melon. Increases, cardiac output goes up, and the total peripheral resistance, TPR, total peripheral resistance, decreases. That's why you have increased cardiac output, decreased resistance, so that's how come you don't get hypertension. Now, what happens is that GFR increases, however, the renal threshold decreases, so you start to spill glucose. Because what happens is normally you should not start to hit transport maximum in the kidney until your glucose goes to 200 or so. But a pregnant woman will spill glucose earlier. Increase in plasma volume, decrease in resistance. That's why you should not get hypertension. Now, the pituitary enlarges, and one of our favorite questions is, why do you get panhypopituitarism after delivery? Is because this now large pituitary all of a sudden loses its blood supply after birth, and poof, it involutes and infarcts. Sheehan syndrome, panhypopituitarism. You get decreased everything. Why? Because it's kind of like saying, well, you don't have a pituitary. The pituitary, it's not so much the pituitary is making the T4 and the cortisol, but you're losing TSH. You're losing ACTH. You're losing growth hormone, but remember that growth hormone deficiency is not noticeable in adults. You'll lose FSH and LH. Now, that's Sheehan syndrome. Now, you get hyperthyroidism also, but then generally the free level of thyroid hormone stays normal. What you get is an increase in thyroid binding globulin. It causes an increase in the total thyroid hormone, but not in the free. Look, the reason also that hypothyroidism is unusual in pregnancy is because you get an increase in the plasma proteins. What's happening is that estrogen makes binding globulin. Binding globulin binds up the free. When the free goes down, you lose feedback inhibition, and you get more total thyroxine made. Look, there is a lot of physiologic changes of limited consequences. You get an increased plasma volume, one of the most important. That means if you have cardiac defects, what is the most dangerous cardiac lesion to a pregnant woman? What is the most dangerous cardiac lesion to a pregnant woman? And the answer is anything with right ventricular hypertrophy, pulmonary hypertension, Eisenmenger's phenomena. Eisenmenger's. Because you get a 50% increase in plasma volume, but no change in your cardiac dimensions. In a normal person, it makes no difference. In pulmonary hypertension, it makes a big difference. pulmonary hypertension, you can't handle the blood that's going through there. If you have Sheehan syndrome, post-pregnancy pituitary infarction, panhypopituitarism. That's why it says you lose prolactin, you lose T4, you lose cortisol. Estrogen increases the binding globulins. Androgens decrease them, estrogens increase them. It increases the total, but what effect does it have on free thyroxine? Nothing. It just increases the total. Estrogen increases renin, but overall doesn't have a big effect on that renin-angiotensin-aldosterone system. Now, it is true that the pubic symphysis and cervix becomes a little more flexible and distensible, but you know what? We don't know what to do with it. This is something called relaxin. Nice name, right? Relaxin, put you in relaxation, nice. But there's no deficiency and no excess disease. Now, oxytocin receptors. We've never described a deficiency or an excess of oxytocin, which means a woman with no pituitary can still give birth. Oxytocin makes more oxytocin receptors. Estrogen makes oxytocin, oxytocin, estrogen, and that's the only other positive feedback loop we can think of. What initiates parturition is unknown. Unknown. What helps it along? Relaxin opens up your pubic symphysis, and oxytocin from your posterior pituitary, which causes a positive feedback loop, and boom, you give birth. By the way, what's the strongest muscle in the human body? The uterus. The uterus is twice as strong as your masseter. The masseter is strong, but the uterus is stronger. If the masseter and the uterus ever had a fight, the uterus would squeeze the crap out of that masseter. 120 pounds per square inch. Tremendous. So if you're pregnant, you can remove the pituitary and you don't have to have oxytocin. Now, you can't conceive without either FSH, LH, or the estrogens you need to induce ovulation, because you need the pituitary to have ovulation. But let's put it this way. If you're pregnant, there's nothing in the pituitary that's essential to give birth. If you're not pregnant, of course we need FSH and LH to be able to make your ovulation. However, interestingly enough, you could actually chemically simulate that. You can actually give stuff to induce ovulation. You don't have to have oxytocin. It helps, but you don't have to have it. It's like candy. It's nice to have it, but it's not mandatory. Parturition, I like that. We're parting. From what? Your baby from the uterus. We do not. Finally, we get to finally admit we don't understand something. We don't know why. Oxytocin induces uterine contractions. However, we don't have to have it. Increased oxytocin does not initiate the contractions. It helps so we can give it therapeutically to induce labor, but it's not essential in a normal person. Now, we're finishing up on this chapter, and let's look at lactation. Lactation happens because estrogen makes the mammary tissue grow. Now, prolactin also makes the glands grow. However, the high plasma estrogen, although it increases prolactin secretion, milk synthesis does not occur. Don't waste food. We don't want to be making the milk when you're not there to drink it. So estrogen makes the breast grow, makes the gland grow, but doesn't let the milk flow. Now, at parturition, estrogen drops. Why does estrogen drop? Because the placenta is gone. When the placenta leaves, the estrogen level drops. When the estrogen level drops, the milk will flow. You withdraw the block. And what happens? The milk flows. Now this also, ready? A first-time mother has just given birth. She puts her baby immediately to her breast to nurse the baby and is very upset that the milk is not flowing. What is the etiology? What is the mechanism? Persistently high progesterone level, persistently high estrogen level, insufficiently high prolactin level. loss of growth hormone, too much cortisol? The answer is, what prevents the milk from flowing is the high estrogen level. A woman who's a first-time mother on the following day is able to nurse her baby. Which of the following is the mechanism? Rise in prolactin, drop in progesterone, rise in estrogen, drop in estrogen, drop in estrogen allows the milk to flow. Now, here's our final picture of our oblong breast here. Now remember that when baby suckles there, when baby's sucking, it's not a vacuum cleaner. The baby's not like a Dyson that doesn't lose suck. The baby is squeezing the nipple, and the nipples are connected to the brain, which makes the oxytocin squeeze the myoepithelial cells, which give a forward pass on that breast milk. The nipple squeezing goes to the posterior pituitary, which contracts the myoepithelial cells. Now, next thing is that when you have nipple stimulation, what happens is that you have an increase in prolactin. The nipple stimulation decreases the release of dopamine. Nipple stimulation decreases dopamine. Dopamine is also known as prolactin inhibitory factor. Nipple stimulation decreases the dopamine. When you decrease the dopamine, prolactin goes up. When the prolactin goes up, the milk will be made and will flow. Next, this is a very big deal. The nipple stimulation and the prolactin inhibit GnRH. This is extremely important. A woman is nursing her baby and is continuously sexually active, yet does not conceive. What is the mechanism? Increasing prolactin, decreasing GnRH. It's better to say decreasing GnRH, because it's in fact the inhibition of the hypothalamic release of gonadotropin-releasing hormone that prevents the ovulation. It's 95% protective. 95%. Not good enough for me, but 95% protective. And basically, the mechanism is like this. It's bad enough to be having one baby to feed, but if you become pregnant and give birth to a second baby, you have one baby here and you get another baby here, but this would be like being in a restaurant that's very busy and trying to seat two people in the same chair, the same table. Excuse me, wait until the first customer is finished eating. Then have the second customer come in. So it's the same as having a maitre d' in your head. The first customer is eating, stop the production of GnRH, stop the LH and FSH, stop the ovulation. That is what will make it so that you don't, because you can see that if you have a woman who's under conditions of starvation and she's feeding two babies at the same time, those people will be dead. Now, this lactation thing has a lot of good questions. Prolactin makes the machinery. Estrogen makes the machinery but prevents the milk from flowing. Why doesn't the woman make milk as soon as she delivers? Because it needs the estrogen levels to drop. When she does make milk, produce the milk, estrogen levels have dropped. Why is it that a woman can't conceive, doesn't conceive when she's nursing? Because of high prolactin inhibiting GnRH. A baby's major way to get the milk out is not by negative pressure. It's not literally suckling. It's a reflex to the posterior pituitary squeezing the myoepithelial cells, not physical suckling. Let us look at this whole thing. You ready? The follicular phase is variable. The follicular phase is characterized by estrogen. The follicular phase is characterized by estrogen, which makes the endometrial cells grow and also can make later on the breasts grow if it gets really big enough. You say, well, that's why women's breasts, by the way, do swell with their menstrual periods. Not as much as when you're pregnant. but they do swell with your menstrual period some because there's some, as the estrogen level rises for about a week. It is an LH surge that makes you ovulate. The luteal phase is always fixed at 14 days. That's a big question because it's cycle length minus 14 is when you ovulated. The luteal phase is characterized by progesterone. Progesterone makes the endometrial lining secretory. Progesterone makes your body warmer. You are so hot. Ay, está caliente. Ay, qué lindo. Ay, qué lástima. And why? Because progesterone makes you hot and closes off that cervix with the mucus. That's the first part of it. Menses is passive. Unless you rescue the corpus luteum at 14 days with HCG, estrogen and progesterone will go down and the endometrial lining will slough off. In other words, like the Batman movie. He goes, well, Bruce, still hesitant to do what you have to, still won't go far enough. And he goes, you're right. But I'm not going to kill you. I'm not going to kill you. But I don't have to save you either. I don't have to kill you. I'm not going to kill you, but I don't have to save you. So that's like menstruation. It doesn't kill off the endometrial lining, but it's not going to save it either. The estrogen and progesterone levels drop down, the endometrial lining sloughs off. Now, if you do conceive, you conceive on day 15, you implant on day 20, your trophoblast starts to make HCG by about day 25. These are approximations because we're learning. If somebody goes up and says, couldn't it be day 26? Yeah, it could be. But it can't be day 28 because they're going to be out. The HCG rescues the corpus luteum. The HCG rescues the corpus luteum. The corpus luteum will continue to make progesterone and estrogen. If you don't rescue the corpus luteum, it sloughs off and you have menstruation. If you do rescue the corpus luteum, you're rescuing it, and for the first 1/3 of the pregnancy, it is the trophoblast in its process of becoming a placenta that makes HCG that continues to save the corpus luteum to make the progesterone. If you don't have progesterone and estrogen, it sloughs off. Now, in the second 2/3 of the pregnancy, you have a placenta. The placenta makes the estrogen and progesterone it needs to maintain itself and gets by with help from its little friend. Gonna try to make a little help from my friend. Do you need anybody? I need a fetal adrenal to love. Could it be anybody? Oh, I need DHEA to love. Oh, I need a water-soluble androgen. Oh, I need it to get the placenta to get in. Yes, do you need anybody? Yes, I need a fetal adrenal. I need that fetal adrenal to make enough progesterone and estrogen, and I take advantage of it by sending DHEA down from the fetus. Now, gestational diabetes mellitus is from human placental lactogen under conditions of starvation. Why is it that you have no ovulations? You have no ovulation because you have a decrease in gonadotropin-releasing hormone as an effect of the prolactin. Suckling causes oxytocin. GnRH is inhibited by the suckling and the prolactin. Human placental lactogen is responsible for gestational diabetes. Cycle length minus 14 is when the ovulation is occurring. You can remove the ovary after the first 1/3 of the pregnancy, but don't do that. And you need the fetal adrenal to help make the extra sex hormones. Wow, you have survived female reproductive endocrinology. As long as you accept that at the beginning, the estrogen is inhibitory until it becomes stimulatory, boom, and it explodes, and so do I.